How to reverse hypertension. What actually works. Doctor explains. I am Dr. Robert, and after 2 decades immersed in cardiac surgery, I have personally witnessed the devastating effects of hypertension on the human cardiovascular system. I have performed thousands of surgeries, meticulously examining arteries and holding diseased blood vessels in my hands, gaining an intimate understanding of what high blood pressure truly inflicts. This profound experience has led me to a stark realization: the conventional understanding of reversing hypertension, and indeed much of what we are told about managing it, is fundamentally flawed. For too long, the prevailing notion has been that high blood pressure is akin to a plumbing issue, a matter of excess fluid in the circulatory system. Doctors often advise reducing salt intake or prescribe diuretics, believing that by removing excess water, blood pressure will normalize and the problem will be solved. However, this simplistic view, rooted in outdated models from the 1970s, is not only incomplete but actively hinders true healing. It is a narrative that keeps us trapped in a cycle of management rather than promoting genuine recovery. The reality of hypertension is far more intricate and demands a paradigm shift in our thinking. It is not about the volume of fluid within our arteries. It is about the arteries themselves. They are not merely conduits carrying blood. They are dynamic, living tissues that become damaged, brittle, and rigid. At a microscopic level, structural changes occur that no pill, no matter how potent, can rectify. When I operate, the difference is stark. A healthy artery, when incised, springs back with supple elasticity, alive and responsive. In contrast, an artery affected by hypertension is hardened, calcified, and resistant to manipulation. It often crunches when cut, demonstrating a rigidity that makes even passing a needle through its walls a challenge. This inherent stiffness, this structural degradation, is the true essence of hypertension. What is often left unspoken is that pharmaceutical interventions, while capable of managing the numerical readings on a blood pressure monitor, do not address this core issue of rigidity. These medications work by altering fluid volume or influencing vessel tone, thereby lowering the numbers. Yet they fail to repair the structural damage or restore the lost elasticity of the vessel walls. They offer a temporary fix, a band-aid on a problem that necessitates a deeper, more fundamental intervention, a form of cellular and structural remodeling at the most minute levels. This, in essence, is what true hypertension reversal entails. By the conclusion of this exposition, you will gain a comprehensive understanding of how to achieve this, including the identification of 3 underlying mechanisms that initiate hypertension, mechanisms rarely explained by conventional medical practitioners due to their limited understanding. Furthermore, you will be equipped with a 4-step protocol designed not merely to manage, but to actively reverse the damage that underlies your condition. This is not theoretical speculation. It is grounded in cellular biology and validated by my own clinical experience with patients who were once told they would require lifelong medication. Commit your attention to what follows, for the knowledge you are about to acquire holds the potential to liberate you from the perpetual reliance on blood pressure medication. Let us begin by delving into the cellular underpinnings of hypertension, the microscopic landscape I observed during surgical procedures. Your arteries are far more than simple tubes. They are intricate, living organs composed of 3 distinct layers. The innermost layer, the one that directly interfaces with your circulating blood, is the endothelium. This exquisitely thin lining, consisting of a single cell layer, is more delicate than tissue paper, yet it extends throughout every blood vessel in your body. Its function transcends mere containment. It is an active participant in maintaining vascular health. The endothelium is responsible for synthesizing vital chemicals that govern blood flow, prevent the formation of dangerous clots, modulate inflammatory responses, and ensure the overall well-being of your vessels. When the endothelium is healthy and functioning optimally, your blood pressure remains within a normal range. Conversely, damage to this critical layer is a primary driver of hypertension. What is often overlooked, even by many medical professionals, is that the endothelium is further protected by a microscopic layer known as the glycocalyx. Imagine this as a sophisticated, non-stick coating akin to Teflon, lining the interior of your arteries. This protective shield is constructed from a complex matrix of sugar molecules and proteins, measuring only a few micrometers in thickness. While invisible to the naked eye, its importance to the cardiovascular system is profound. The glycocalyx performs several crucial roles. Firstly, it creates a remarkably smooth and slippery surface, allowing blood to flow with minimal friction. Secondly, it acts as a barrier, preventing inflammatory molecules from reaching and damaging the underlying vessel wall. Thirdly, it plays a sensory role, detecting blood flow and signaling the endothelium to release nitric oxide, a crucial gas that promotes vessel relaxation and dilation, thereby maintaining open pathways for blood. When your glycocalyx is intact and undamaged, your vessels retain their health and flexibility, and your blood pressure remains stable. However, when this protective layer is compromised, the entire vascular system begins to falter. The primary culprits behind glycocalyx damage include elevated blood sugar levels, chronic inflammation, the habit of smoking, and oxidative stress. These detrimental factors can erode the glycocalyx with the destructive power of acid on Teflon. Once this protective coating is stripped away, the delicate vessel wall is exposed. Inflammatory molecules can then adhere to the endothelium. White blood cells can begin to attach to the vessel surface, and LDL cholesterol can penetrate the wall, initiating the insidious process of plaque formation. Simultaneously, the endothelium's ability to produce nitric oxide diminishes, leading to vessel constriction and increased stiffness. This cascade of events culminates in elevated blood pressure. This is the first fundamental mechanism of hypertension, the destruction of the glycocalyx. Crucially, none of the commonly prescribed blood pressure medications are designed to repair this damage. ACE inhibitors, calcium channel blockers, and particularly diuretics do not restore the glycocalyx. They aim to manage the pressure readings, but the underlying damage, the eroded Teflon coating, persists. Consequently, while individuals may achieve controlled blood pressure numbers on medication, their vessels remain vulnerable, silently progressing towards potentially catastrophic events like strokes and heart attacks. This explains why individuals on blood pressure medication can still experience cardiovascular events. The medication addresses the symptom, not the root cause. Consider the case of David, a 67-year-old gentleman who had been on a regimen of 3 blood pressure medications for 8 years: amlodipine, lisinopril, and hydrochlorothiazide. His blood pressure was consistently well controlled, registering at 128/82, and his physician was pleased with these numbers. David himself felt generally well. Then, one morning, he suffered a heart attack. Though not a catastrophic event, it necessitated his admission to my operating room for bypass surgery. Upon opening his chest, the extent of the problem was immediately apparent. His coronary arteries were severely calcified and rigid. Attempting to sew a bypass graft onto one of these arteries proved exceedingly difficult, the needle barely penetrating the wall, which felt as unyielding as concrete. I remarked to my assistant that despite 8 years of medication controlling his blood pressure, his vessels had clearly not been protected. David survived the surgery, but his case highlights a critical failing. His medication managed his pressure, but failed to preserve his arterial health. The years of treatment had fostered a false sense of security, leading both David and his doctors to believe that controlling the numbers equated to controlling the disease. This misconception proved tragically inaccurate, as the underlying disease had been silently progressing throughout that time. This leads us to the second pivotal mechanism of hypertension: arterial stiffness, a factor that is often completely overlooked by mainstream medicine. While doctors diligently monitor blood pressure readings, focusing on systolic and diastolic numbers like 120/80 or 140/90, they frequently neglect to assess the actual condition of the arteries, whether they are pliable or rigid. This distinction, however, is of paramount importance, arguably more so than the numerical values themselves. To understand why, we must examine the composition of a blood pressure reading. The systolic pressure represents the force exerted on arterial walls when the heart contracts, while the diastolic pressure reflects the force when the heart relaxes. In an individual with healthy, flexible arteries, these numbers might be around 120/80. The difference between these two figures, known as the pulse pressure, provides a crucial indicator of arterial stiffness. Typically, a normal pulse pressure ranges from 40 to 50. However, as arteries stiffen with age or due to disease processes, a significant shift occurs. The systolic pressure tends to rise, while the diastolic pressure often falls. This can result in readings such as 160/70. While the systolic pressure is elevated, the diastolic pressure is unexpectedly low, leading to a wide pulse pressure, often exceeding 60. This pronounced difference signals a significant loss of elasticity in the arteries, particularly the aorta, the main artery emanating from the heart. Mechanically, in a healthy, flexible aorta, when the heart pumps blood, the vessel expands to absorb some of the surge in pressure, acting as a natural shock absorber. This buffering effect helps to moderate systolic pressure. Subsequently, as the heart relaxes, the aorta recoils, continuing to propel blood forward and maintaining diastolic pressure. This elegantly orchestrated elasticity ensures a smooth, regulated flow of blood. However, when the aorta becomes rigid, it loses this capacity to expand and absorb pressure. Consequently, the full force of the heart's contraction is transmitted directly and forcefully throughout the arterial system, causing a sharp spike in systolic pressure. When the heart then relaxes, the stiff aorta is unable to recoil effectively, failing to maintain adequate pressure, leading to a drop in diastolic pressure. The outcome is a wide pulse pressure, a high systolic reading coupled with a low diastolic reading. This specific pattern is a more potent predictor of stroke and heart attack risk than the individual blood pressure numbers alone. For instance, an individual with a blood pressure of 160/100 has elevated pressure but relatively normal arterial stiffness, resulting in a pulse pressure of 60. In contrast, someone with a blood pressure of 160/70, while having the same systolic reading, exhibits severe arterial stiffness, leading to a pulse pressure of 90. The latter individual faces a significantly higher risk of cardiovascular complications. Yet most physicians do not calculate pulse pressure. Instead, they observe a high systolic number, like 160, and promptly prescribe medication to lower it, entirely missing the underlying problem of arterial stiffness. This diagnostic oversight can be attributed to a simple fact: there is no pharmaceutical readily available to directly reverse arterial stiffness. If a doctor were to measure it and find it elevated, they would have no pill to prescribe to correct it. Therefore, the focus remains on what can be treated with medication, the pressure reading itself, rather than the quality and health of the blood vessels. In my professional opinion, this constitutes a form of medical negligence, as arterial stiffness is, in fact, reversible, not through medication, but through targeted structural remodeling, precisely the kind of intervention outlined in the protocol I am about to share. To understand how arterial stiffness develops, we must examine the structure of the artery wall, which consists of 3 layers. The innermost layer, the endothelium, has already been discussed. The middle layer, known as the tunica media, is composed of smooth muscle cells and elastic fibers, and it is this layer that grants arteries their flexibility. The outermost layer comprises connective tissue that provides structural support. In a healthy artery, the tunica media is elastic, allowing its smooth muscle cells to contract and relax, and its elastic fibers to stretch and recoil. However, with advancing age, and particularly in the presence of hypertension, diabetes, or chronic inflammation, several detrimental changes occur within this middle layer. Firstly, calcium deposits begin to form. Calcium is essential for bone health, but its presence within arterial walls is profoundly damaging. When blood vessels become inflamed, calcium ions migrate from the bloodstream into the tunica media, where they crystallize, rendering the vessel wall rigid and inflexible. Secondly, the elastic fibers within the tunica media break down and are progressively replaced by collagen, a stiff and inelastic protein. Thirdly, the smooth muscle cells undergo a transformation, ceasing to function as muscle and beginning to exhibit characteristics of bone-forming cells, actively contributing to the calcification of the vessel wall. This process, termed vascular calcification, is the primary driver of arterial stiffness. By the time individuals reach their 60s, especially if they have a history of prolonged hypertension, their arteries can more closely resemble bone than functioning blood vessels, becoming calcified, rigid, and impervious to reversal by conventional blood pressure. Medications. ACE inhibitors do not facilitate the removal of calcium from vessel walls. And while calcium channel blockers can help relax smooth muscle cells by limiting calcium entry, they do not address calcium already deposited within the vessel wall. Consequently, the calcification and the associated stiffness persist. The crucial question then arises, is it possible to reverse arterial calcification, to remove calcium from artery walls and restore vascular flexibility? The answer, and this is a critical point, is a resounding yes, but not through pharmaceutical means. Reversal is achievable through specific nutritional and mechanical interventions that are largely unfamiliar to many medical practitioners. I will elaborate on these methods within the protocol. However, before we proceed, it is imperative to understand the third fundamental mechanism, one that intricately links the previous two, the insulin-kidney lock. This mechanism provides the explanation as to why salt restriction often proves ineffective for many individuals, why diuretics offer only transient relief without addressing the underlying problem, and why some people can consume salt liberally without experiencing elevated blood pressure, while others meticulously restrict their salt intake, yet their pressure remains stubbornly high. The linchpin of this mechanism is insulin. Our kidneys play a vital role in regulating blood pressure by controlling sodium levels. In an ideal scenario, when sodium intake is high, the kidneys efficiently excrete the excess. Conversely, when sodium intake is low, the kidneys conserve it to maintain adequate blood volume and blood pressure. This intricate regulatory system, however, is contingent upon the kidney's ability to respond appropriately to hormonal signals. The challenge arises because insulin actively impedes sodium excretion. When insulin levels are elevated, the kidneys are signaled to retain sodium, irrespective of dietary intake. This physiological response has evolutionary roots. Insulin is released in response to food intake. In ancestral environments where food was scarce, conserving essential nutrients, including sodium, was crucial for survival, ensuring adequate blood volume and pressure during periods of fasting. However, in the context of modern lifestyles characterized by constant eating and chronically elevated insulin levels, this mechanism becomes pathological. The kidneys remain locked in a state of sodium retention, perpetually recycling sodium from the body. Consequently, blood volume escalates, leading to sustained high blood pressure. This explains why salt restriction often fails. The issue is not necessarily the salt itself, but rather the inability of the kidneys to excrete it due to high insulin levels. The true lock is insulin, not salt. To elucidate this further, insulin exerts its influence on the kidneys through several pathways. Firstly, it directly stimulates the reabsorption of sodium in the proximal tubules of the nephron, the filtering units of the kidney. Increased reabsorption means less sodium is excreted in urine and more remains in the bloodstream. Secondly, insulin activates the sympathetic nervous system, prompting the kidneys to release renin. This initiates a cascade that ultimately leads to the release of aldosterone, a hormone that instructs the kidneys to retain sodium and excrete potassium. Thirdly, insulin enhances the sensitivity of blood vessels to angiotensin II, a potent vasoconstrictor, causing them to constrict more aggressively in response to the same signals. Thus, high insulin levels contribute to sodium retention, activate hormonal pathways that further promote sodium retention, and cause blood vessels to constrict, all of which elevate blood pressure. This is why individuals with insulin resistance, prediabetes, or type 2 diabetes almost invariably experience hypertension. Their elevated insulin levels effectively lock their kidneys into a state of perpetual sodium retention. A critical point to understand is that insulin resistance can exist even in the absence of overt diabetes. Fasting blood sugar and HbA1c levels may appear normal, yet individuals can harbor significantly elevated insulin levels. This hyperinsulinemia can silently drive hypertension and damage blood vessels for years before glucose levels begin to rise. Most physicians do not routinely test for insulin levels, focusing instead on glucose and HbA1c. If these are within the normal range, they may erroneously assume insulin regulation is functioning correctly. The reality is that elevated insulin, even with normal glucose readings, can wreak havoc on the vascular system and elevate blood pressure. This condition, known as hyperinsulinemia, is one of the most prevalent yet frequently overlooked causes of hypertension. Therefore, if you have high blood pressure and salt restriction has proven ineffective, the root cause may not be dietary sodium, but rather elevated insulin levels, keeping your kidneys locked in a state of retention. Until this insulin lock is released, no amount of salt restriction will adequately normalize your blood pressure. Before we delve into the specific protocol for reversing these three interconnected mechanisms, I must implore you to take two important actions. Firstly, please subscribe to this channel immediately. What I am about to reveal in the subsequent section holds the potential for life-altering change. Detailed steps for repairing glycocalyx damage, decalcifying your arteries, and unlocking your kidneys. You will not want to lose access to this vital information, so subscribing ensures you can find it again and share it with those who desperately need it. Secondly, kindly give this video a thumbs up. Your engagement helps more people discover this crucial information that many of their doctors are not providing. A simple click could empower thousands to understand the true causes of their hypertension and how to effectively address them. Thank you for your support. Now, let us shift our focus to the process of reversal. The inaugural step in reversing hypertension is the restoration of your glycocalyx, that vital Teflon-like coating within your arteries. Remember, a healthy, intact glycocalyx shields your vessels, while its damage initiates inflammation and plaque formation. So how do we rebuild this essential protective layer? The first imperative is to halt its destruction. The primary agents responsible for glycocalyx degradation are high blood sugar and oxidative stress. Every instance your blood sugar surges above 140 TARS mg DL, it inflicts damage upon the glycocalyx. Sugar molecules react with proteins within this coating, a process known as glycation, which renders the coating stiff, dysfunctional, and prone to disintegration. Therefore, step one is to stabilize your blood sugar. This doesn't necessarily mean eliminating carbohydrates entirely, but rather ensuring your post-meal blood sugar levels remain consistently below 140 mg/dL. For most individuals, this necessitates a reduction in refined carbohydrates and an emphasis on whole foods, vegetables, legumes, and select fruits, while rigorously avoiding sugars, white bread, white rice, pasta, and pastries. These foods trigger rapid and significant blood sugar spikes, and each spike inflicts damage upon your glycocalyx. Secondly, it is essential to provide your body with the fundamental building blocks required to reconstruct the glycocalyx. This protective layer is primarily composed of molecules called glycosaminoglycans, which are long chains of sulfated sugars. While your body possesses the capacity to synthesize these molecules, it requires specific raw materials. The most effective dietary sources of these essential sulfated polysaccharides are found in seaweed, particularly fucoidan from brown seaweed and caiman from red seaweed. Scientific studies have demonstrated that these compounds can restore glycocalyx thickness and enhance endothelial function. While you can incorporate seaweed into your diet regularly, readily available supplements containing fucoidan also exist. Research indicates that doses ranging from 500 to 1,000 pinomolaris daily are beneficial. Thirdly, you must actively reduce oxidative stress. Oxidative stress arises from free radicals, unstable molecules that inflict cellular damage. While some free radicals are a byproduct of normal metabolism, their production is significantly amplified by factors such as smoking, pollution, processed foods, chronic stress, and excessive exercise. These free radicals directly attack the glycocalyx, breaking the chemical bonds that hold it together. To combat oxidative stress, you need an abundant supply of antioxidants, ideally sourced from whole foods rather than solely from supplements. The most potent antioxidants for vascular health are polyphenols, found in a vibrant array of colorful vegetables and fruits, including berries, leafy greens, beets, dark chocolate, and green tea. These foods are rich in compounds that effectively neutralize free radicals before they can damage your glycocalyx. Let me illustrate this with the case of Thomas, a 70-year-old gentleman who had lived with hypertension for 15 years and was taking 2 medications. His blood pressure was controlled at 132/84, and while his pulse pressure of 48 was acceptable, his laboratory results indicated elevated markers of endothelial dysfunction. I explained to him that despite his controlled blood pressure, his vessels were inflamed, and we needed to repair the vessel lining, not merely manage his pressure. We initiated a comprehensive protocol, eliminating refined carbohydrates, introducing a fucoidan supplement at 1,000 mg daily, significantly increasing his intake of polyphenol-rich foods, specifically 1 cup of berries and 2 cups of leafy greens daily, and completely eliminating all processed foods. After 3 months, we repeated his endothelial function test, which directly measures the blood vessel's ability to dilate in response to increased blood flow, serving as a direct indicator of glycocalyx and endothelial health. His initial test revealed poor dilation, only 4%, while normal function is above 10%. Following 3 months on the protocol, his dilation improved to an impressive 12%, signifying a restoration of vascular flexibility and healing of the glycocalyx. His blood pressure, which had been 132/84 on 2 medications, subsequently dropped to 118/76. We were able to reduce one of his medications. After 6 months, he was completely off both medications, his blood pressure remaining normal at 122/78. His glycocalyx had healed, his endothelium was functioning optimally, and he no longer required medication to manage a symptom because the underlying cause had been addressed. This is the tangible outcome of reversing hypertension. Now, let us move to the second critical step: decalcification, the process of removing calcium from your artery walls and restoring their natural flexibility. This aspect of vascular health is perhaps the most misunderstood. Many individuals believe that once calcium has deposited within their arteries, it is a permanent and irreversible condition. This is a misconception. Calcium can indeed be removed from arterial walls, but this requires a thorough understanding of the underlying mechanisms. Calcium does not randomly accumulate in the vessels. It is actively transported there by specific proteins and retained due to the absence of other critical proteins. The key player in this intricate process is a protein known as matrix GLA protein, or MGP. MGP acts as a biological traffic controller for calcium. When MGP is activated, it directs calcium to its proper destination, your bones. However, when MGP remains inactive, calcium is free to migrate into the arteries and deposit within the vessel walls. The crucial factor for MGP activation is vitamin K2, specifically the MK7 form, distinct from vitamin K1, which is primarily involved in blood clotting. Without adequate vitamin K2, MGP remains dormant, allowing calcium to accumulate in your arteries and leading to vascular stiffening. Conversely, with sufficient vitamin K2, MGP becomes active, redirecting calcium out of your arteries and back into your bones. This mechanism has the potential to reverse arterial calcification. Evidence from animal studies has shown a significant regression of calcium deposits in severely calcified arteries following vitamin K2 supplementation. Furthermore, human studies have demonstrated that vitamin K2 supplementation can slow or even halt the progression of arterial calcification. The effective dosages utilized in these studies range from 180 to 360 micrograms daily of MK7. Obtaining this amount from dietary sources alone is challenging. It would require daily consumption of natto, a fermented soybean product which is not a common dietary staple for most. Therefore, supplementation is generally recommended. However, vitamin K2 is only one part of the equation. Calcium requires a cofactor to be effectively incorporated into bone, and that cofactor is vitamin D. Vitamin D enhances calcium absorption from the gastrointestinal tract and facilitates its deposition into bone tissue. Without adequate vitamin D, the calcium redirected by vitamin K2 has nowhere to go, potentially leading to other issues. Thus, a synergistic approach involving both vitamins is essential. Vitamin K2 to activate MGP and facilitate calcium removal from arteries, and vitamin D to promote calcium uptake into bones. The third vital component in this process is magnesium. Magnesium acts as nature's calcium channel blocker. When magnesium levels are adequate, it inhibits calcium from entering the smooth muscle cells within the vessel walls, thereby promoting relaxation and preventing constriction. Conversely, magnesium deficiency allows calcium to flood into these cells, causing them to contract and blood vessels to constrict, ultimately raising blood pressure. Beyond this direct effect, magnesium also plays a crucial role in preventing the formation of calcium crystals within the vessel walls. Even in the presence of calcium, magnesium helps keep it dissolved, thereby inhibiting the development of calcified deposits. Unfortunately, magnesium deficiency is widespread. Modern diets, often lacking in dark leafy greens, nuts, seeds, and whole grains, foods rich in magnesium, contribute to this deficiency. Furthermore, various factors deplete magnesium levels, including stress, alcohol consumption, diuretic medications, and proton pump inhibitors used for acid reflux. The cumulative effect of these factors leaves the vessels unprotected, allowing calcium deposits to form freely and arteries to calcify, leading to hypertension. The solution lies in magnesium supplementation. However, not all forms of magnesium are equally effective. Magnesium oxide, commonly found in inexpensive supplements, is poorly absorbed, with only about 4% entering the bloodstream, while the remainder can cause gastrointestinal distress. Superior forms, such as magnesium glycinate or magnesium threonate, are highly absorbable and effectively deliver magnesium to the bloodstream and cells where it is needed. For vascular health, a daily dosage of 400 to 600 milligrams is recommended. Allow me to share the case of Margaret, a 73-year-old woman who had struggled with hypertension for 2 decades and was taking 4 medications. Her blood pressure was barely controlled at 138/88, and more concerningly, while her pulse pressure was 50, a CT scan of her chest revealed severe calcification of her aorta, placing her at extremely high cardiovascular risk. We initiated a decalcification protocol, prescribing vitamin K2 at 360 micrograms daily, vitamin D at 5,000 IU daily, as her levels were low at 28 ng/ml, and magnesium glycinate at 600 milligrams daily. We also optimized her diet to increase her intake of magnesium-rich foods. After 6 months, we repeated her CT scan. Her calcification score had decreased by 8%. While this might seem modest, any regression in arterial calcification, which is typically a progressive condition, is remarkable and indicative of the protocol's efficacy. Her blood pressure had also improved to 124/80, allowing us to reduce her medication regimen to 3 drugs. After a year, her calcium score had decreased by an additional 15%. Her blood pressure was now 118/76 on 2 medications. 18 months into the protocol, she was on only 1 medication with perfect blood pressure control. The decalcification protocol had demonstrably restored her arterial flexibility and initiated vascular remodeling. This exemplifies what true reversal looks like. The third crucial step in reversing hypertension involves the restoration of nitric oxide. Nitric oxide is a gas produced by our endothelial cells and plays one of the most vital roles in our cardiovascular system. When nitric oxide is released, it diffuses into the smooth muscle layer of the blood vessels, signaling the muscle to relax. This relaxation leads to vasodilation, allowing blood to flow more easily and consequently lowering blood pressure. Healthy endothelium continuously produces nitric oxide, maintaining relaxed vessels and normal blood pressure. However, when the endothelium is damaged, particularly when the glycocalyx is compromised, nitric oxide production diminishes. This inability to relax leads to vessel constriction and elevated blood pressure. The enzyme responsible for nitric oxide synthesis is called endothelial nitric oxide synthase, or ENOS. This enzyme is susceptible to damage from the same factors that degrade the glycocalyx: high blood sugar, oxidative stress, and inflammation. Therefore, repairing the glycocalyx, as outlined in Step 1, inherently contributes to restoring ENOS function. However, there are specific interventions that can further enhance nitric oxide production. Firstly, it is imperative to ensure an adequate supply of the raw material for nitric oxide synthesis, the amino acid L-arginine. L-arginine is readily available from protein-rich foods such as meat, fish, eggs, dairy, and legumes. If your diet is sufficiently protein-rich, you are likely consuming enough L-arginine. Supplementing with additional L-arginine typically does not yield significant benefits, as the limiting factor is not the raw material itself, but the efficiency of the enzyme. The ENOS enzyme requires several cofactors to function optimally, the most critical being tetrahydrobiopterin, or BH4. When BH4 levels are adequate, ENOS efficiently produces nitric oxide. However, when BH4 is depleted, ENOS becomes dysfunctional, leading to the production of superoxide, a harmful free radical, instead of nitric oxide. This condition is known as ENOS uncoupling, and it is detrimental to vascular health, transforming an enzyme meant for vessel relaxation into one that generates damaging molecules. BH4 depletion is exacerbated by oxidative stress. Therefore, reducing oxidative stress, as addressed in Step 1 through the consumption of polyphenol-rich foods, indirectly protects BH4. However, we can also directly support BH4 levels. While a supplement called sapropterin dihydrochloride can boost BH4, it is a prescription-only medication and can be costly. A more accessible, natural approach involves ensuring adequate intake of folate, vitamin C, and vitamin E. These vitamins play a crucial role in regenerating BH4 and preventing ENOS uncoupling. Folate derived from leafy greens, as opposed to synthetic folic acid from supplements, vitamin C from citrus fruits, berries, and peppers, and vitamin E from nuts and seeds are all essential. Secondly, it is vital to stimulate the ENOS enzyme itself. ENOS is activated by a phenomenon called shear stress, which is essentially the friction generated by blood flowing across the endothelium. When blood flow increases, this friction activates ENOS, leading to nitric oxide production and vasodilation to accommodate the increased flow. This is precisely why exercise effectively lowers blood pressure. The elevated blood flow during physical activity creates shear stress, activating ENOS and producing nitric oxide. With regular exercise, the endothelium becomes more responsive to shear stress, leading to increased nitric oxide production even at rest, thereby lowering baseline blood pressure. However, a specific type of exercise has been found to be particularly effective in stimulating nitric oxide production: isometric hand grip training. This involves squeezing a hand grip device at 30% of your maximum strength for 2 minutes, followed by a 1-minute rest, repeating this cycle 4 times. Numerous studies have demonstrated that this specific protocol can lower blood pressure by 10 to 15 points systolic within 8 weeks. The mechanism behind this efficacy lies in the sustained muscle contraction, which compresses blood vessels in the forearm. Upon release, this creates a surge of blood flow, generating substantial shear stress in the forearm arteries. This shear stress powerfully activates ENOS, leading to a systemic release of nitric oxide. Over time, this repeated stimulation enhances ENOS sensitivity, increasing baseline nitric oxide production and reducing blood pressure. Research unequivocally shows that isometric hand grip training is as effective as medication in lowering blood pressure, but with the significant advantage of actually addressing the underlying problem by retraining the endothelium to produce nitric oxide optimally. Thirdly, a simple yet often overlooked intervention is nasal breathing. When you breathe through your nose rather than your mouth, your nasal passages produce nitric oxide. This nitric oxide is inhaled with each breath, entering your lungs and subsequently your bloodstream. Studies have shown that nasal breathing can increase blood nitric oxide levels by up to 600% compared to mouth breathing, leading to improved oxygen absorption and enhanced vascular function. This is why individuals who consistently practice nasal breathing, particularly during exercise, often experience significant improvements in their blood pressure. The nitric oxide generated by their nasal passages supplements their endothelial nitric oxide production. This intervention is entirely free, requires no equipment, and simply involves consciously breathing through your nose. For those who are mouth breathers during sleep, even taping the mouth shut at night can lead to dramatic improvements in oxygenation and nitric oxide levels. Consider the case of James, a 65-year-old gentleman with a decade-long history of hypertension, managed with 3 medications. His blood pressure was 136/86. We implemented the nitric oxide restoration protocol, increasing his intake of folate, vitamin C, and vitamin E through dietary sources, initiating isometric hand grip training 4 times per week, and switching to nasal breathing during his daily walks. After 2 months, his blood pressure had dropped to 124/80, allowing us to reduce one of his medications. 4 months later, his pressure was 118/76, and we reduced another medication. After 6 months, he was on a single medication with perfect blood pressure control. His endothelium had recovered, his NOS was once again producing nitric oxide efficiently, and he no longer needed medication to artificially lower his pressure because the fundamental mechanism had been repaired. This illustrates the profound impact of addressing the underlying cause rather than merely managing the symptom. Finally, we arrive at the 4th and most transformative step, the insulin reset. This is the critical process that unlocks your kidneys, enabling them to excrete sodium effectively and thereby regulate blood pressure. As we have discussed, elevated insulin levels create a lock on your kidneys, compelling them to retain sodium, rendering salt restriction futile if insulin remains high. Therefore, the primary objective of this step is to lower your insulin levels. The most potent strategy for achieving this is through time-restricted eating, a method that involves condensing your daily food intake into a specific time window and fasting for the remaining hours. Scientific research unequivocally demonstrates that during periods of fasting, insulin levels drop, and upon eating, insulin levels rise. The longer you fast, the lower your baseline insulin becomes. For individuals with hypertension, I recommend a fasting period of 16 hours, coupled with an 8-hour eating window. For example, you would consume all your meals between noon and 8:00 p.m., fasting from 8:00 p.m. until noon the following day. During the fasting window, only calorie-free beverages such as water, black coffee, or plain tea are permitted. This regimen provides your body with a 16-hour period free from insulin spikes. During these extended fasting hours, your insulin levels will decrease to baseline, your kidneys will be unlocked, they will excrete excess sodium, your blood volume will normalize, and consequently, your blood pressure will drop. The research supporting time-restricted eating for blood pressure reduction is remarkable. Studies have shown that this approach can lower systolic blood pressure by 10 to 12 points within 8 weeks, and this occurs without any alteration to the types of food consumed. The benefit is derived purely from the timing of meals, driven by the reduction in insulin. Lower insulin levels directly correlate with unlocked kidneys, which in turn leads to sodium excretion and a subsequent decrease in blood pressure. However, the insulin reset involves a second crucial component, improving insulin sensitivity. Even with time-restricted eating, if your cells are resistant to insulin, your pancreas will continue to produce excessive amounts of insulin to compensate, potentially keeping your overall insulin levels elevated despite fasting. Therefore, enhancing your cells' sensitivity to insulin is paramount. The most effective method for achieving this is through exercise, specifically resistance training. When you engage in weightlifting, your muscle cells develop more insulin receptors, becoming more responsive to insulin. This means your pancreas does not need to produce as much insulin to facilitate glucose uptake into cells, leading to a reduction in baseline insulin levels. Studies indicate that incorporating resistance training 2 to 3 times per week can lower fasting insulin by 20 to 30% within 12 weeks. This improvement in insulin sensitivity effectively unlocks your kidneys, normalizing sodium excretion and lowering blood pressure. A secondary strategy for improving insulin sensitivity involves incorporating specific foods into your diet. Vinegar, cinnamon, and berries have all been shown to enhance insulin sensitivity when consumed regularly. Apple cider vinegar, for instance, slows down carbohydrate digestion and mitigates the post-meal insulin spike. Research suggests that consuming 1 teaspoon of vinegar before meals can reduce post-meal insulin levels by 20%. Cinnamon, when consumed daily at a dose of 1 teaspoon, has been shown to improve insulin sensitivity by 10 to 15%. Berries, particularly blueberries, contain anthocyanins that positively influence insulin signaling. Regular consumption of berries has been linked to measurable improvements in insulin sensitivity. While these are seemingly minor interventions, when combined with time-restricted eating and resistance training, they create a powerful synergistic effect for an insulin reset. Let us consider the case of Robert, a 68-year-old gentleman diagnosed with hypertension and prediabetes. His fasting glucose was 108 mg/dl, his HbA1c was 5.9%, and crucially, his fasting insulin level, which I specifically tested, was 18 MIUL, nearly double the normal range of below 10 MIUL. This elevated insulin was a significant contributor to his hypertension. We initiated the insulin reset protocol, a 16-8 time-restricted eating schedule, resistance training 3 times per week, 1 teaspoon of apple cider vinegar before meals, and 1 teaspoon of cinnamon daily added to his coffee. After 8 weeks, his fasting insulin had decreased to 11 MIUL. His blood pressure, which had been 142/88 on 2 medications, had improved to 128/80, allowing us to reduce 1 medication. After 16 weeks, his insulin level had normalized to 8 MIUL, and his blood pressure had further improved to 118/76, enabling us to eliminate his second medication entirely. For the past 2 years, he has remained off all blood pressure medication, maintaining normal blood pressure readings of 122/78. His insulin levels are now normal, his kidneys are unlocked, and they excrete sodium appropriately. He no longer requires medication to artificially lower his blood pressure because the underlying mechanism driving it has been corrected. This is the essence of reversing hypertension, not managing symptoms or controlling numbers, but addressing the fundamental mechanisms at play. This involves 4 key areas: glycocalyx restoration, arterial decalcification, nitric oxide normalization, and insulin regulation. By addressing these root causes, blood pressure naturally normalizes as your body's inherent healing capabilities are engaged. I understand that the prospect of implementing 4 distinct protocols involving multiple supplements, dietary changes, exercise regimens, and timed eating may seem complex. This is precisely why I am developing Senior Health Life Daily, a community platform where I will share detailed protocols that extend beyond the scope of what can be covered in these videos. I am currently finalizing an ebook titled The Vascular Remodeling Protocol, which will encompass all the essential information, precise supplement dosages and recommended brands, specific dietary guidelines, step-by-step exercise instructions, a structured time-restricted eating plan with meal timing strategies, methods for tracking your progress using specific tests, and guidance on how to safely collaborate with your doctor to reduce medications as your blood pressure normalizes. This comprehensive ebook will be exclusively available to members of Senior Health Life Daily. To join, please click the link provided in the description below and enter your email address. You will be among the first to be notified upon its launch. My commitment is to provide purely educational content, free from advertisements and sales pitches, empowering you with the tools to regain control of your vascular health. Join our community and become part of a movement that has the potential to transform lives. It is important to clarify that I am not advising you to discontinue your blood pressure medication abruptly, as this could be dangerous. My recommendation is to view medication as a tool for symptom management while these protocols address the root causes. Ideally, you should commence these protocols while continuing your prescribed medication. As your blood pressure consistently improves, work closely with your physician to gradually reduce your medication dosage. Monitor your blood pressure daily and observe the trends. When your numbers show sustained improvement, then and only then should you discuss medication reduction with your doctor. Never cease medication without medical supervision, and never reduce dosages without your doctor's guidance. However, do not resign yourself to the belief that you will be on medication for life. This is often the message conveyed because conventional medicine primarily focuses on managing blood pressure rather than reversing vascular damage. You now possess a deeper understanding, the role of the glycocalyx, the implications of arterial calcification, the importance of nitric oxide, and the insidious insulin-kidney lock. By comprehending these mechanisms, you gain the ability to effectively address them. This distinction is what separates management from reversal. Management entails lifelong medication, whereas reversal involves structural repair. Pills manage the numbers. This protocol repairs the damaged vessels. Today, I have unveiled the truth about hypertension. It is not a simple plumbing issue related to fluid volume, but rather a consequence of structural damage to your arteries at a microscopic level. This damage manifests as a compromised glycocalyx, calcified vessel walls, diminished nitric oxide production, and insulin resistance that effectively locks your kidneys in a state of sodium retention. Conventional medical approaches fail to address these fundamental causes, offering pills that merely manipulate pressure without repairing the underlying damage. However, you now have the knowledge and the tools to repair this damage through glycocalyx restoration, achieved through blood sugar control, sulfated polysaccharides, and antioxidants. Decalcification, supported by vitamin K2, vitamin D, and magnesium. Nitric oxide restoration, enhanced by shear stress exercises and nasal breathing. And insulin reset, facilitated by time-restricted eating and resistance training. These 4 steps directly address and reverse the mechanisms driving hypertension. When these mechanisms are reversed, blood pressure normalizes not through external force, but because your vascular system has been repaired. This is what I have consistently observed in my patients. David healed his glycocalyx and discontinued 2 medications. Margaret reversed her arterial calcification, transitioning from 4 medications to just 1. James restored his nitric oxide production and eliminated 2 medications. Robert reset his insulin levels and completely discontinued all blood pressure medication. These are not miraculous occurrences. They are the predictable outcomes of applying cellular biology principles and addressing causes rather than symptoms. You now possess this invaluable information, knowledge that many physicians lack. This is information that can liberate you from medication and serve as a powerful shield against stroke and heart attack. Utilize it. Begin today. Choose one step and start there. Perhaps begin with glycocalyx restoration by eliminating refined carbohydrates from your diet, or initiate the insulin reset by implementing 16-8 time-restricted eating. Alternatively, focus on nitric oxide restoration through isometric hand grip training a few times this week. The key is to simply begin. Every day that your vessels remain stiff and damaged represents another day closer to a cardiovascular event. Conversely, every day you implement these restorative protocols is a day of healing. If this video has illuminated your understanding of what hypertension truly is and how to reverse it, I urge you to watch one more video. Click the link that is appearing on your screen right now. It is titled, "The One Blood Pressure Medication That Actually Heals Your Arteries." In that video, I will reveal a specific medication that, when used in conjunction with these protocols, has been shown to actively repair vascular damage rather than merely managing pressure. This is critical information that builds directly upon everything you have learned today. Click now before you forget, and remember to subscribe to this channel if you have not already done so. My unwavering unwavering commitment is to share surgical knowledge that can help you avoid the need for my operating room. Take excellent care of your vessels. They are the only ones you have. And remember, hypertension is not a life sentence. It is a reversible condition. If you are willing to understand the underlying mechanisms and dedicate yourself to addressing them, the choice to heal is yours. Choose reversal.